All right, so I hit record. Perfect. So welcome. Thanks for joining again. Small group. So it's very much just raise your hand, ask questions, just whatever as we go through. Please feel free to do that and make it a conversation. But like I mentioned, this meeting is being recorded. So we will share the recording link and the slides to everyone that we invited to this within the next week. And you can feel free to reference it, share it with other staff or whatnot. You can put questions in the chat. You can just speak up, and we will have time at the end for questions too. This will not take a full hour. We're just going to go through this grant and what it's kind of composed of and give you a chance to ask questions. So first, just to introduce us on the call, from FDR-HPO and NCI, I'm Joanna Loomis. I'm the Deputy Director here at NCI. I know all of you, and I think you're all pretty familiar with our team, but just to be on the safe side, I'm joined by my colleagues, Tracy Hart, Ian Francis, and Heather Petrie. They are all practice transformation specialists here at FDR-HPO and NCI, and they work with our clinical and behavioral health and other partners on various value-based contracts that they're in and other initiatives and things that we do with them. So that is us. And I mean, I think we normally don't do introductions of the attendees, but it's Aileen and Tina and Cassie. Do you all know each other? Okay, all right. I figured as much. All right, so we're just going to go over the basics of this grant, get into a little bit of the details. What will this mean for you, basically? We'll talk about some next steps, and we'll leave time for questions, answers, and discussions. And with that, I will turn it over to Tracy.
Morning, girls. So first, acronyms, because we live in a world with 100 acronyms. We will drop this slide into the chat so that you can reference it during the call. But as Joanne said, we will share the slides after the call, so you'll have them to reference there too. The basics. The HRSA grant is going to run from July of this year to June of 2027. There's 4 goals that Joanna will discuss in the next couple slides. And then our list of partners, we have several partners that are going to be a part of this grant. They're in 2 groups. First, the clinical primary care or behavioral health group, and then the community-based social care organizations. The first group, because they have patients assigned to them, will have more of an involved role, and they will have a version of the webinar. They had a version of the webinar 2 weeks ago. The second group, which is you on the call, community-based social care organizations, your primary role will be to receive and act upon social care referrals made through the transitional and care management process. All partners, except for the ones with the asterisks on the slide, have already signed their memorandum of understanding to participate in the grant. A template MOU was included in our email announcing this webinar. If you need us to resend it, let us know.
All right, thanks, Tracy. So there's 4 main goals for this project, and they're on the screen here. And already you see some acronyms. So, but I'll spell those out. So really, goals 1 and 2 are pretty much aligned. Really, the heart of this grant is trying to improve access to transitional and chronic care management. You may be very familiar with what those are. You might not be super familiar, but in a nutshell, transitional care management, or TCM, is provided to a patient after they're discharged from a hospital setting, and in some cases from an emergency department setting. And it's a great opportunity to make sure that that person has a smooth transition back to their home or community setting, and make sure that, their discharge summary is reviewed thoroughly, that, that's a very vulnerable time for a patient, right? They might have been prescribed lots of new medications in the hospital. They might need follow-up procedures or labs. They might need referrals to social or clinical services. And that is a very, very kind of sensitive time. It's a time when if things don't go well, that patient is at high risk for going back into the hospital or the emergency department for complications or whatnot. So we have seen great success with TCM. Ian's going to get more into that in the next slide, but the gist of it is we do want to improve access to that and chronic care management. And chronic care management, as you probably know, is really designed for people, generally speaking, with 2 or more chronic conditions that are expected to last over a period of time. It's a great way to have a care team connect with a patient on a regular basis. Typically, CCM can be done over the phone. It's often done over the phone and often done over the course of a month or monthly. So it's a way to touch base with a patient pretty regularly about their symptoms, what's going on, status of referrals, status of medications, etc. So we have seen great success with both transitional care management and chronic care management in our value-based work. One factor is that, so typically TCM and CCM are provided by primary care often, although we've started engaging our behavioral health partners in providing these services as well. And those services are reimbursed by insurance companies. So if you have Medicare or whatnot, then your provider is paid to do those services for you. An exception is Medicaid patients. Medicaid patients, because they have health home care management, are not eligible. Their primary care cannot be reimbursed to provide TCM or CCM to them. So back in 2021, we started a pilot to pay our clinical partners to actually conduct TCM for the Medicaid population. And we want to expand that to chronic care management as well. Again, we'll get a little bit more into that in a moment. We also recognize that those encounters, those care management encounters, are great opportunities to assess that person's need for other services, such as, preventive screenings like mammograms, colonoscopies, etc., needed immunizations. And so our third goal is to measure how can we use TCM and CCM to also further enhance the health outcomes of the patients being touched by this grant. So we're going to be looking at care gap closures and also reductions in avoidable hospital admissions and readmissions, and also ED visits too. And then fourth, we want to promote value-based care sustainability. So we operate several value-based contracts. Several of you are actually signed up as a CBO participant or a behavioral health participant in these contracts. None of you currently have attributed patients to you because there's no mechanism currently to do that. But the fact that you're at least signed in is a step in the right direction. It's positioning all of us better to be able to do something with that in the future when we can, more meaningfully engage you in a value-based contract. And this grant is sort of very much in alignment with that principle and that concept. So our fourth goal is, the actual measurable goal is to make sure that our partners, generally speaking, are engaged in at least 3 value-based contracts by the end of the grant. That doesn't mean that each one of you has to be engaged in 3 value-based contracts. It's more, is generally speaking, are there 3 active value-based contracts in our network by the end of year 4? So that's kind of the what, but I'll turn it over to Ian to get a little bit more into the why, so you have that context.
I mean, one of the biggest bottom lines is we want to provide good patient care. And by providing good patient care, what we're really doing is we're helping the patient to better take care of themselves so we can help minimize preventable chronic conditions later in life that will increase healthcare costs. And so with that, what we're doing, that's why we kind of started this transitional care management, because we saw how it worked really well with the ACO. And we started the pilot program with our IPAs or with our primary carers for the Medicaid patients. And even though this is a service that's not reimbursed, we were able to get grant funding to help pay them to offset it to help them do these TCMs. And what we found out is when we're doing these TCMs and this chronic care management is since the patient's starting to get more of the care that they need, it decreased how many times they were going back to the ED or getting readmitted to the hospital. So it actually started showing that they were lowering costs, and a lot of practices saw this lower cost with their patients. So like I said, with ACO, Medicare does pay for TCMs and CCM visits. Medicaid does not, and that's part of why we said we have this grant is so we can help reimburse them so they can receive some revenue to help offset the cost of these things since they're not going to get paid by Medicaid or other insurances. And the ultimate goal with this is to really get them engaged with their primary cares or behavioral health, things like that, whatever they can do. And so, like I said, we have been doing the pilot program for a while. We started small with just the Medicaid population. And like I said, we really have seen some good costs, but the overall end goal is to show Medicaid that this service is beneficial and that they should be reimbursing the practices for doing these things because it really does cut down on healthcare costs. And this also really does align with the value-based arrangement, decreasing costs, improving quality, closing care gaps, and pretty much overall really getting the patients to start taking care of themselves. So that leads us into what kind of roles are we looking for? So with our grant partners, even if you are not able to do TCMs or CCMs because we can't attribute patients to you, all the CBOs are actually really important with this. So we really do need someone to be designated that our point of contact so that we can talk to them, share information, get feedback, things like that, and making sure these staff are attending the grant-related meetings that we have, especially the real major ones, because their feedback's really important. We do talk a lot about TCM, CCMs, but a lot of the CBOs really do play a big part in this because one of the biggest effects with most of these patients is their barriers on why they're not taking care of themselves, why they're not taking medications, why they're not going for mammograms, things like that. And it does with transportation, it does with food, it does with health literacy. And that's why we're getting the CBOs involved. So overall, the biggest thing is to increase the access and to expand TCM and CCM to not just cover Medicaid, but cover all third-party insurances. And part of this program is the way we design it is being able to send out alerts whenever a patient was admitted or discharged from inpatient or the ED so that TCMs can be started right away. And then with this, we can start identifying patients that could benefit from care management or chronic care management. And we have really seen how that chronic care management with some of the more patients with more inclusive needs and barriers, it really does help them overcome and really does help them get healthier, live a better life, and really adhere to their medical things. And that's part of the CCM is involving the CBO because it's one of the things we're doing with the TCMs is we're identifying social detriments and then referring the patients out to CBOs or to where they need to help address those social detriments so we can remove those barriers. then with after this is pretty much what we're doing is we're getting the practices to send this information back to us on who they did TCMs and CCMs so we can track and we can also reimburse them for this. And it's also where we're starting to get back into those meetings is sharing workflows and best practices, how they relate, what's been working for a practice, what has not, so other practices can assimilate or try to see what's going to work for them. And it's like I said, a lot of times this does come back to including the CBOs in this is because they are referring patients out to you. And it's one of the things they need is to get feedback back of what you did for the patient. What have you do to help address their social detriments or barriers so that the practices can actually incorporate that into their care plans so they can continue to push forward and move and help these patients the best way they can so we can increase that value base and help start minimizing healthcare costs, both in the short term and long term. And again, the biggest thing is the feedback. This is a new program. It is a pilot. We have a really good scope on how to implement it. But as you know, there's things that we cannot see, and that's why feedback is really important. So we can help figure out what's working, what's not working, how we can change, what is relevant, and how to implement those things as we continue to go through this HRSA grant to better help these patients. And then one of the biggest thing is participate. It's be an active participate. Please provide feedback. Please look at what's working and helping us get that information to other people so we can try and make this program successful, so we can get these third-party insurance and Medicaid to pay for these services and overall decrease healthcare costs while closing care gaps and providing value-based care. And with that, I will turn it over to Heather.
Part of the grant, clinical partners will be conducting a social determinant of health screening on all patients that they're working with for TCM and CCM. Some partners have already been doing this with our MTCM program, but not for all TCM and CCM patients. This will be kind of new for some practices. When patients screen positive for one or more social needs, clinical partners will include the appropriate social care diagnosis in the patient's charts and on the billing claim. This helps us track social determinant of health barriers in our community. And they will also need to initiate a referral to a social care organization. As a result of this, you guys may see an uptick in referral services. The state of social care referrals varies widely. Some practices do a formal referral to you using a fax or even through their EHR, and some may use a specialized referral form platform like Unitas. Some just give the patient your information and hope that they contact you. And this is something that is not a preferred way. A warm handoff is always the best, I think. So we have adopted here a standardized screening tool, which you'll see here, but there are many different types of tools that people can use to address social determinants of health. Some people use the Prepare tool, and partners who are governed by OMH are required to use the OMH approved tool. Most of them all have the same questions or like questions that can gather similar information. So you'll see on this form, this is the one that we use for MTCM. We're asking about housing and food and nutrition, their living situations, and if they have problems getting access to healthy foods, and also about problems in their homes like bugs or mold, that kind of thing, which all of these we all know affect an individual's health. The next one talks about transportation, utilities, their personal safety, and their childcare. Again, all things that can affect a person's overall health. And this is questions about, again, about personal safety, finances, health literacy, and if they have problems taking care of themselves, and if it's difficult for them to see a provider when they felt like they needed to.
All right, thanks, Heather. So just to kind of recap or summarize, what we're looking for from our social care partners, aka you on the call today, is not for you to necessarily perform transitional care management or chronic care management. You will not be billing us. You won't have to do any of those kind of items. That will be chiefly primary care and behavioral health partners that are in the grant. But we would be seeing your role as chiefly getting the referrals that come out of doing these social determinant of health screens. Some of our partners are doing these now with those Medicaid transitional care management. So like I mentioned earlier, NCI has been paying our clinical partners to do that service since April of 2021. And we made it a requirement that if we're going to pay you for that, you have to conduct that standard screen and then make referrals as appropriate depending on what the person needs. However, that's just, like one person here, one person there. It's not all patients all the time. And we're kind of trying with this grant to step towards that direction of having that done for Medicaid patients for chronic care management, and then also asking them to do the social determinant of health screening tool on any patient of any payer type when they're getting TCM or CCM services. So this is fairly new for our clinical partners. So we're really asking them to proliferate using that tool. We believe this is the direction healthcare is headed in. And so we want to prepare our partners to do those screenings, have it be more kind of just part of their workflow, just like those PHQ-9s used to be a very alien concept. Now they're just normal. It's just part of what they do when you go to the office. They ask you those questions. So you may see, as Ian mentioned, you may see an uptick in some of the referrals from clinical and behavioral partners. And again, we are not utilizing any platform specifically for this. This is kind of low tech, low key. We don't want to get too ahead of ourselves as far as that's concerned. So that'll be a discussion topic, I suspect, as we move forward, talking about, is the way that you're getting the referrals meet your needs? Could you get them in a better way from clinical partners, right? And then when you actually see the patient, is there a good method for you to give information back to the clinical partner about what happened? Were you able to see them? Were their needs met, et cetera? So when we think about next steps, first, as Ian mentioned, who should be involved from your team? We will have quarterly touch base meetings. These will be all partners. So because the roles are pretty different, we wanted to do these kickoff webinars with first kind of the clinical organizations and also and then separately with the social care organizations. But moving forward, we would all be together in the same meeting to not silo the conversation. So that's where I think we'll get into a little bit more of how are things going? How is that referral flow, that pattern? Are there improvements that can be made? What are we seeing in terms of needs in the community? That's also where we will have a data dashboard and we'll start reporting out to you what were the baseline measurements, how are we improving or not on those? So you'll start to see the actual metrics and data flow out of this. So for some of you, you might be the one that attends those quarterly meetings. And for some of you, you might feel it's appropriate to delegate that to another person on your team. What we'll do within the next week is I will go ahead and invite all of you to that quarterly meeting series. You can accept it. You can forward it to whomever on your team you feel is appropriate. So just know that that'll be something that will be an immediate next step. And then, as we mentioned, you may receive some increased referrals from clinical organizations. And then we will also, on our end, update our regional social services inventory. We created an inventory when we started the Medicaid Transitional Care Management project back in April of 2021. you guys are probably all laughing because you all know there's a whole bunch of different inventories. Tina's created one before, Eileen's created one before. Like there's a whole bunch of them. There's 2-on-1, there's this and that and the other. Our approach has been very low tech, just like a Excel spreadsheet that could be a PDF'd out. That's just like literally food, housing, like what are all the different places that could help with that. Although we would absolutely change it and improve it based on people's feedback too. So we will work on that. We'll probably put that out to all of you to just make sure, do we miss anybody? And you can have a chance to kind of have feedback on that inventory. So that's really what we're looking at for immediate next steps. So definitely want to open it up for any questions or discussion that anyone has on the call.
Hey, Joanna, this is Ed. I have
Cool.
a question. I came in a little bit late,
No
but
worries.
kind of looking at what you guys are talking about and care management right now, how is, how is it really different? I'm just trying to figure it out because I know transitional care management, care management is one of the big things that we utilize in care management. And then I know Ian was talking about seeing if the MCOs would be on board in the future, with Medicaid billing, because Medicaid billing is already through care management. So I'm just trying to figure out how this is going to not kind of impede the care
Yep.
management model. And as far as sustainability, I know with the grant, how is that going to, I know you guys haven't got that far yet, but I'm just thinking in a model financial wise, and then duplication of services, how is that all going to work?
Yes. And I think you're probably chiefly referring to health home care management. Is
Yeah.
that correct? Okay. So yeah, we got this same question when we did this yesterday too. So it's a good one. So a couple things. One, I think one chief one is that there's two main points. One is that the health home care management model is promising, but it sort of, from our perspective and our clinical partners, specifically primary care, it doesn't really foster as deep a connection with primary care as we would love to see. And there's probably lots of reasons for that. Some that are not, maybe some that are beyond the control of the actual health home care managers. But this is a chance to, part of value-based care is putting accountability on the entity to which the patient is assigned. And so these patients in value-based care contracts are attributed to primary care, even if they're not even seeing primary care. And this is an opportunity to introduce some more accountability to the primary care partner to say, here's your patients that are assigned to you. They're going to the ED a lot, right? Or they're going to the hospital. You got to follow up with them and provide this service to them. And then we would reimburse you for it, is really what we're looking to do. And I think ideally we would see, that kind of connection with primary care happen with health home care management. And no doubt it is in some cases, but maybe not universally. So this is sort of a chance to try and bring those two worlds together in a way that hopefully, I don't believe it will be duplicative. The second piece is that I think we all know that part of the approved New York State budget was a sort of a downsizing or whatnot of health home care management. And so you're going to see a lot of patients who are going to be kind of forced in a way out of health home care management after a certain period of time, or because they're a lower acuity patient. Those patients, there's no clear direction, at least from what we see, as to how to continue care managing those patients in a way that's sustainable. It feels like they'll be kind of floating around, and there's a sort of vague assumption that maybe there'll be more community health workers, maybe but that's sort of an unfunded mandate. So this is a chance to kind of divert some grant funds to help support those patients. And the thought is that patients coming off of that health home care management could sort of be brought on a Medicaid chronic care management program so that that continuity isn't lost. So that was probably a rambling answer to your question.
No,
Ed.
no, it
I
makes
don't know.
sense. It does make sense. I know there's been, the budget and the things with that.
Yeah.
I think with the model that you guys are trying to outline here, I think it's important because it allows the primary care to have accountability and an incentive a little bit to make sure that you're kind of making those referrals flow and continuity of care is being there, but it allows them to have some more accountability towards that as a partner. So I can see the difference. Whereas care management, yes, we're doing that a little bit more, but it's more of an outside referral that can come in, and that care manager is kind of working with that interdisciplinary team. Whereas this put a lot of onus on the primary care accountability, but it's also some incentive behind that. So that is that model is a little bit different, and it can work.
Thanks for your question and comments.
So Joanna, I have a couple questions. One is around the
Yes.
invite. Is it limited to one person?
Nope.
Okay, I'm
Nope.
just thinking that initially it'll probably be me, but I'd also like our referral coordinator on that as we're talking about closed
Yes.
loops and what's happening there in terms of
Yes.
referrals. So that was my first question. Is there going to be a push towards Unitas? I know that's kind of been part of the 1115 and coming into that whole piece, or do we know how many people are currently utilizing Unitas? I know we have a account. I know we don't use it a lot. So I was just curious as to what your thoughts were around the platforms.
Yeah, that's a great question. So from our perspective, just speaking with partners, it feels like some of you may technically have Unitas accounts, but it sort of feels like it's maybe not being very robustly utilized. And please correct me if I'm wrong. That referrals are a mixture of organic connections and phone calls and faxes, and Unitas is just one way to kind of get there. We at North Country Initiative have been pretty agnostic when it comes to those types of referral platforms. I guess we've been a little skeptical because they come with a really high price tag, and we had concerns about their sustainability. And so that's why we really didn't jump in kind of head first into adopting that kind of a platform. And we've really just, again, kind of low tech, sort of just capitalizing on the natural relationships that a lot of you have with each other. So the 1115 waiver does talk about platforms. It's pretty platform insistent. It feels like every region, unless things change in whatever version the waiver ends up being. But it sounds like, each region would have to adopt some platform. Unitas definitely feels kind of like a front runner, but I would say in speaking with other regions in the state, there's other platforms out there. Find Help, there's a couple others that seem promising. So long story short, we are sort of cautiously not. We've researched some of the platforms. Tracy on the call has done some kind of more in-depth research on them, but we're not wedded to any of them. And in fact, if we could figure out a way to do something that was just more simple and seamless, we would totally like that approach. Like, even if, say, like Healthy Connections, if they could basically weave that into their model, we would be interested in exploring that because it's one less thing to sign into. So does that answer your question at all?
Yeah, no, yeah, it does. And then I guess my final question was around what you're currently doing with your social determinant of health screens. I know you said it was limited. How are you seeing those referrals? Are you seeing them making referrals? Are you seeing, of all of the providers that have the capability of doing that, are you seeing just one or two of them doing it? What's that looking like right now?
So that's a little bit of a black box for us because there's no way to track it. And that is the beauty of a referral platform, is we would actually be able to, like, in one standardized way, track those. Right now, we're basically saying we can audit our partners if we can come back and say, all right, show me in the chart that you did this, and and did you actually do the screening, and did you code the appropriate social diagnosis, and did you, conduct the referrals? I don't have standardized data that shows the number of referrals that have gone out. So that is a weakness of our model for sure, and something that I think this grant could help us push in the next direction. Like, for instance, just yesterday, our team was talking about how can we better facilitate referrals, maybe without even using a platform. And it feels like every EHR has the capability to do a fairly easy, click a couple buttons and send a fax to NERCL, to NCPPC. I don't know how well that's being done. If that happens, Tracy, you probably would know this. If they do that, it sounded like that would have been a trackable thing. We would be able to look in their EHRs and see how many of those referrals were initiated, correct? Okay, she's nodding. I trust Tracy. She knows her EHRs. So that could be a kind of a low key way to try and do that work. That doesn't necessarily mean that we would have to full blown adopt like a full platform. So I don't know. We don't know.
So
And then
Go
I
ahead,
guess
I'm
my
sorry.
last question is around workflow. I think we just got a call from somebody. It's like, oh, we didn't know you existed. And I'm like, how for insurance enrollment? And I'm like, how does that happen? How does a organization that relies, or a provider that relies on insurance coverage, not know how to reach out to people to get their patients or consumers coverage? I mean, we do reach out, or we do a lot of outreach, but how do we get it from the top or the manager or whoever down to that frontline person or care person that's going to make that referral?
Mm-hmm. So I'll start, but I feel like my colleagues have some ideas on this. So please, please, please chime in. I think there's crazy staff turnover, right? You can teach one and that.
Yep.
So there's got to be some way that we, again, it could be like our very basic service inventory, making sure that insurance navigation enrollment is one of those items, along with food and housing and the other pieces that we have on it, and getting that out to our care managers, our referral coordinators, and all of the clinical organizations and community-based organizations who are at the very least part of this grant, if not part of our larger clinically integrated network. Heather used to work at North Country Family Health Center. She had her own book and she literally printed it periodically and put it in people's offices. And it was very much like she had to really manage that process. So to the extent our team can help facilitate that with our partners, I think it's going to take that constant reminder that this is the list of resources in the region. Heather, would you add anything to that though? I don't want to
Nope.
speak for you.
No, having a tangible book that was designated for housing and Jefferson, Lewis, or St. Lawrence County was very helpful. And I think it goes back to, if we want people to do the social determinant of health screening, we have to be able to let them know who to refer to. They're going to be more apt to ask those questions, but they feel comfortable in knowing that they know who to outreach to get these individuals for. So I think it's an ongoing problem. It's something that I discussed as a community health worker about not knowing exactly who brings what to the table. And sometimes it might just take an old-fashioned get-together, talking, and giving others information about what they do provide, so that we can maybe get something set up for those who are doing social determinant of health screenings, and even for CBOs to know who's doing what and who has funds for what too.
Thanks for that.
I think that
What
covers
other-
all me.
Okay. Good thoughts and questions, Tina. What else?
Well, this is Aileen. So when you say so I hear the word partner, used, and I'm not sure if you're talking about healthcare, behavioral health, clinical partners, or are you talking about all of the IPA members when you say part?
So for grant, this grant has a specific network of partners that largely overlaps with our IPA, but it's not perfect.
Okay.
And one thing we literally didn't even talk about, and part of what influenced that, and I'll just mention it, is that this is a HRSA grant. And so we have to really make sure that the funds are going exclusively to HRSA defined rural patients. And if you know HRSA, you know that they have a very distinct definition of what's rural. And in our region, all of Lewis County is rural, as it should be. All of St. Lawrence County is considered rural, but only pieces of Jefferson County are considered rural. It's like A-Bay and Clayton and Wilnon. I might be missing one, but that's it. You know, Worth isn't rural. Rodman isn't rural. Haha, but you know, that's just the way they define it. So part of HRSA is that we have to have a network, and that network has to be at least 2/3 rural, meaning they are either located in or chiefly serve those rural patients. So, so there's some Jefferson County specific entities that are sort of not that are in our IPA that might not be in this grant because we needed to keep that 2/3 rural kind of balance. Just it's a technical requirement. So like Church and Community Program in Canton, they're not in our IPA. There's several others that are not in the IPA, but they're in this grant as a partner. Our clinical partners, for the most part, I believe are all in the IPA except for Community Health Center of the North Country. They are not in our IPA, but given their rurality, this was a great way to kind of start to partner with them in a tangible way. And it could be a win-win for everyone involved.
Okay.
Yeah.
So, so I heard, I'm kind of going through these notes. I should have written down the questions and not just the notes. So I was writing down the things that you were saying. So care management encounters are good times to talk about usual screenings, vaccines, etc. Are you talking, when you say those care management encounters, are you talking about the care management encounters when your clinical providers call people up and do their care management work that you're paying them for? Is that the care management encounter you're referring to?
Chiefly, yes. Although no wrong door approach, if another person or partner was able to make that connection, no wrong door, absolutely great. But yes, we're basically charging our clinical partners, if you're going to be doing these chronic care management services, really use that as a great opportunity to connect with the patient about things that are maybe outside that specific little bubble of care management that you're used to talking with them about.
Okay. So then you also talked about your value-based partners and getting partners ready as that for value-based contracts. Are you talking about the CBOs at this point, or are you still talking about your clinical providers who are not engaged in a value-based contract?
Both. Yeah,
Okay.
it'd be both. And goal 4 is sort of a foregone conclusion that we'll meet goal 4. It's just goal 4 is worded as that our network in general need to be active in at least 3 value-based contracts by the end of year 4. We're already currently active in at least in 3 value-based contracts. So our goal was to maintain that throughout the course of this 4 years and hopefully add up to that. You know, we're looking at seeing what we can do to proliferate those contracts with other payer types as well. But as you know, we've just started adding community-based organizations to our IPA. And we're, looking at again, there's it's a soft add. There's not a defined role for them at this moment because everything comes down to patient attribution and there's no mechanism by which to attribute patients to those community-based organizations. Just this year, we started attributing patients to the clinical behavioral health organizations and the IPA, so CRADO and Children's Home and TLS. And that's like step one, sort of like a step in the right direction, but we have a lot more steps to take. So.
Okay. I know, I mean, I, as a former member, because it doesn't exist anymore, of the North Country Behavioral Healthcare Network, we've been asking FDRHPO to include us in value-based payments for years and have gotten the same, no, we're not ready yet. No, they're not ready yet. There's no way to do this. So, so that's good that at least Credo and the children's home are in. So you also talked about sending out alerts on admits and discharges to help identify patients who could benefit from this. Now, Healthy Connections does that. So are you going to do another alert?
Yes. We've done this
Lost
for
your voice.
years. Oh, sorry. Can you hear me?
I can now.
Yeah, okay. Yes, we've done this for a while now. Let me actually escape out of this PowerPoint and stop sharing. I think I stopped sharing. Can you still
we
see my
send alerts
screen?
every single day, and we call up our patients every single day. We have a discharge. We call them up.
Yeah.
That's in, and this is semantics, but it's also important to say that it's not just good patient care. It's how people have a better life. I don't really care what the patient care is. I want people to have a better life.
Yeah.
So for some people, it's not calling them. Like, please stop calling me. Okay, I stop calling you because it's a better life for you if I don't call. Great, that's what I want. So, it sounds like semantics, but it's also kind of core for us. But I do want to understand a second alert.
Yeah. So we've done this for several many years now with our Medicare value-based partners to augment their transitional care management efforts. So what we do is we have an internal application that ingests the admission, discharge, transfer alerts that are generated by Healthy Connections for all of our attributed patients. And then we would basically kind of clean it up. Thanks, Ed. Have a great day.
Bye, Ed.
We clean it up because, as I'm sure you know, the ADT alerts can be fairly voluminous, and it does require a little bit of sorting through because you're probably not going to call someone just because they're admitted or just because they're discharged. It's really a lot of the transfers, and it's only certain types of transfers or discharges that really are kind of truly actionable. So we wrote code to sort through all of that volume and then augment it with basically spitting out maybe a more readable, like one sheet of paper alert. And that's what you see on the screen. And we add some other information to it that you might not see with those ADT alerts that you get from Healthy Connections. So this is a redacted example of one that was actually generated within the last, few weeks. And you can just see, that it shows you where they were discharged from and when, where they went, how long was their length of stay, if it was a hospital stay, what was their visit reason, which can be helpful, and then how many ED and inpatient visits have they had in the last 12 months. And our hope there is that can be a tool to help sort of be like, wow, this person, like, here at the bottom, 4 ED visits in the last 12 months might be just a poke that this person
on the same day. So it looks like, are they all ED visits or are they like a transfer from one floor to the other? I mean, I don't know, but 3 in one day, that seems kind of like a transfer.
For which one?
IP admits in the last 5 days with no discharge notification.
Okay, so yeah, so let me see if I can do.
But it doesn't matter. I don't want to get in the weeds.
Yeah.
I just wanted to understand that there's a second alert system coming.
Yes. This here is showing inpatient discharges. This is ED. Over here, these are different people. These are all different people. And it's just sort of heads up. These people have been admitted to these various facilities, but they haven't been discharged yet. So these are kind of like, hey, heads up. These are going to be future transitional care management opportunities for you.
Okay.
Yeah.
Yeah, we just screen for the discharges and call when they get out.
Yeah.
Don't bother people when they're in the hospital.
Yes.
When you get out, we'll go get you. All
Yep,
right.
exactly.
Touch base. That's great. Why not home healthcare management? because it doesn't foster a connection. Yeah, we could work on that. But I also understand the lower acuity patients will be dropped soon, and you know, so there's
Bye,
that.
Tina.
Bye, Tina. Oh, I had one more question about, so in your screening, are you collecting the referral data? Can you audit the referral data for when the primary care doc sends the people to the ER? Because that is an issue. I mean, we have now, I have 4 or 5 certified community health workers, and I've got 10 more in the pipeline. So there are NERCL advocates who are completing their certification.
Yeah.
And I can tell you the number of, I'm at the ER because my doctor couldn't see me, said I should go here. Like seriously, this is huge.
Yep.
It's huger than maybe your partners want to admit. But if you're auditing them for that information, you will see that they're not, you know, for every 1 referral they sent to NERCL, there's 4 referrals to the emergency department.
Yep. I'm not shocked by that. I see Heather going like this. She's not surprised by that either. And it's definitely not what we want to see happening. It very much, to me, ties back to that New York Health Foundation project that we did, where we were speaking with chiefly Medicaid patients about their access to primary care and experiences. And it was very loud and clear that, you know, a lack of same-day appointments.
I'm saying it's not just Medicaid, it's my staff.
Yeah. Okay. Yep.
My staff are getting referred to the ER department.
Yes.
We even Dallas.
Yep. Yes. Yes.
So I don't know if there's not enough staff at the primary care to handle the number of people who are coming through. In which case you got to staff up. But if you're not stepping up because you're not getting enough money, then we need to advocate for better reimbursement or something. Something else in the system is wrong, is my theory. Because I mean, yeah, because this I mean, we had a staff member in the ED. You were part of the Max project. You know, it works. There's no doubt about it. It works. Focusing on Medicaid folks. But right now, there's enough things going bizarre in the healthcare system that it's more than this. And that's my concern.
Yes. Yep. We hear you for sure.
So are we dealing with it?
In whatever way we possibly can. I don't pretend to have a magic solution for it, but what we've tried to do is talk with the partners that this is an issue. And again, I think we did that when we had the New York Health Foundation report, that sort of shone through as one of the findings. We've had at least one partner change their workflow by widening their appointment hours. And they are now like accepting walk-in patients. And I take that as a huge win. And it's a step in the right direction. That's one partner. Okay. It's not everybody, but if we can keep making these types of changes, I feel like we got to just capitalize on that and do what we can with it. So, and I would say too, it aligns with this project. That's what this project is trying to get at in various different ways. MCCM, which is chronic care management for the Medicaid population, really owned by primary care and in some cases behavioral health care, was piloted by one small practice in Jefferson County. They did a fabulous job of really trying this out, digging deep, and they had some great findings. And one of the findings was, and I don't have it up, so I can't give you the exact figure, but that once they engaged with that patient through this Medicaid chronic care management, those patients then started calling them when they had minor acute issues instead of automatically going to the ED. And they kind of said, you're kind of our VIPs. Like, you call us, you need something, we'll get you in, we'll make it work. And so that was amazing to see. And that's what we want to see happen, that now they're going to be engaged and that this practice is going to know their name. They're going to know who they are and hopefully be more apt to say, no, don't go to the ED. We need to get you in. Let's handle that today. So I guess I would say that. it's not perfect, but I do feel very strongly this is a step in the right direction.
I don't disagree. I just want to make sure we're looking at the big picture and not, I'm a slightly concerned that that the accountability will become on the CBOs. No, don't go to the emergency room, go to NERCL. They'll take care of it. Because we get those referrals. And I'm like, we're peer support. Like, seriously, that's what they sent you? Oh, okay, come on in. Let's figure out what we need to do. And we try to figure out a lot, and we do a lot of figuring out, and we see people who are have acute illness on many different levels. But I just am a little bit nervous that that's where the accountability will fall, is on the CBOs, because NERCL couldn't help them, or MHA was closed, or, you know, I just want to make sure that the clinical stuff, the clinical providers are still accountable for the clinical stuff, and the CBOs, you know, are here, you know, and yeah, that anybody doesn't know that North Country Perinatal Council will help get you insurance, that anybody doesn't know that seems to me remarkable. I mean, it's remarkable.
Mm-hmm. Yeah.
And maybe there's a backup in the system as well, where we do more education with the human services curriculum at JCC, because I know there's a lot of new people out in the community and new hires, and that is all good. But the Holly Armstrongs aren't there who used to bring us in.
Yeah.
And maybe that's an issue. Maybe there's a thing that we can back up and do something there to
Yeah.
and improve the knowledge base of people who are coming to work at CBOs.
Yep.
Just a thought. I just, you know, just trying to figure out how we can help everybody live a better life.
Mm-hmm.
I appreciate the grant. I'm excited about the opportunity. We're happy to take all the referrals that we possibly can. And like I said, we are staffing up and educating up. We use some federal funding to offer anybody who wanted to get their community health worker certificate, we're going to pay for that. And that's all coming through Aspen, because the free one in New York is specifically for maternal and child health. And, you know, we're like different.
Yeah.
Happy to make referrals. We make referrals to NCPPC all the time, but
awesome. Well, that's very exciting. More community health workers. We talked about, if we could just have an army of them, that would be great.
I'm trying to build it, and I'm trying to build it among people who are disabilities, you know, so we know this, we know how the work flows. We're not, you know, we're not the people who are out. I mean, although we are people who, so many people who I hire just want to help people. All right, so stop with that. All right, if you just want to help me, go get my grocery cart and have it available when I walk in the door. That will be helpful. But who are engaged in changing the system. I mean, if we're the ones who are affected as people with disabilities, and we need to be engaged in changing the system. So
yes,
we're working on that.
Absolutely.
All right, those were my questions, and if there's anything we can do to help, or to help educate the providers, we're happy to do that too.
Appreciate that very much. Any other questions, thoughts? Cassie, anything?
No, I'm just here to listen, because I don't know how much we can help, and I want to get ahead of the game. I want to make sure that we're involved in things, that we're keeping our pulse on things, that we're not, you know, having to rush at the last minute. But at the current juncture, I don't see where we fit in as a puzzle piece. Our role is completely different, completely different, but we're here to help and support and do and give information and make sure that things are getting out to the people.
Yep. Oh, Aileen, you're mute.
Yeah, sorry, I have to jump. I've got an interview that started 8 minutes ago.
Perfect.
Sorry.
All right. Well,
people
then we'll end here. I appreciate you all. More information to come in the next week. Have a great rest of your week.
Bye.
Appreciate it. Bye.